Good morning, class. Last lesson I introduced about the definition of obstetric emergencies, and I also gave various examples. So today I would like us to start with the first obstetric emergency, that is ruptured uterus. Basically, let's go back to what we covered in first semester, the structure of the normal uterus. And we have basically talked about on the different layers of the uterus. We talked about the size of the uterus. We talked about the measurement of the uterus. And for a few quick reminder, one can tell us about the layers of the uterus. We have three. We have the outer layer, which is perimetrium, and basically does not have a major function. We have the second layer, the middle layer, that is the myometrium, which consists of the muscles. And we talked about various types of the muscles, that is the circular muscles, longitudinal muscles, etc., etc. Then we talked about the inner layer, which is the endometrium, and we know about the function. So when you're talking about ruptured uterus, we need to ask ourselves as learners, what does this one mean? And basically, by definition, we are saying it is actually a tear in the wall of the uterus, and it's the most, and it is one of the most serious complications in pregnancy, and it can also occur in labor, though it can be prevented. That's what we are trying to say when we talk about a ruptured uterus. Therefore, the next one we need to understand what are these classification of the ruptured uterus. Basically, we have three classification. We have what we call complete, incomplete, and dehiscence. So, when we mean by complete ruptured uterus, this actually it involves the three layers of the uterus, that is endometrium, myometrium, and the perimetrium. Then we ask ourselves, when complete rupture normally occur, where is the status of the fetus? At this time, the fetus may be ejected into the peritoneal cavity. So students, when you hear complete rupture of the uterus, just conceptualize, click it into your mind that it will involve the three layers of the uterus, which are endometrium, myometrium, perimetrium. Therefore, it means the rupture must start from inside, coming outwards. The second classification is incomplete rupture, which basically involves about the two layers, that is the endometrium and the myometrium, but the perimetrium is not involved. Then the third classification is what we call dehiscence, that is rupture of existing uterine scar, but the fetal membranes remains intact, hence retaining the fetus in the ruptured uterus and not in the peritoneal cavity, as it was in the, at least what we found it in the complete rupture of the uterus. So we ask ourselves, for the ruptured uterus to occur, what could be the predisposing factors? Number one, we are trying to talk about previous history of classical cesarean section. You know, when you go back again to cesarean section, you can be able to ask ourselves, what is classical cesarean section? The other one is neglected mother in labor with previous scar. The other one is high parity. Why high parity? Because of the lax muscles, myometrium muscles. Or we can also get pregnancies occurring within 6 months after cesarean scar. This is basically what we normally try to call it as a fresh cesarean scar when the mother conceives at that time. The other one is obstetric manipulation. And this obstetric manipulation, we are trying to talk things like external cephalic version. When the baby is presenting in a breech, then you try to turn this baby into normal vertex. Then finally, we can get previous operations in the uterus, such as myomectomy. Those are basically about predisposing factors. We need to check about what are the real causes of ruptured uterus. Number one, we are trying to talk about obstructed labor in CPD, that is cephalopelvic disproportion. We ask ourselves, what is obstructed labor? And again, we need to understand what is CPD. Obstructed labor, we are saying this is when the presenting part fails to enter into the pelvic brim despite of good uterine contractions. Then CPD, we are trying to talk about the disparity between the maternal pelvic and the fetal head, in that the fetal head could be too big to enter into the maternal pelvic. Then the other real cause, we are trying to talk about excessive use of oxytocin, especially in high parity mothers. When we don't have to use of this, when you are inducing labor by use of oxytocin. In most of the BMOC facilities, we do not have this infusion pump, so that we can be able to say how many drops per minute are we. Many midwives, they just open the drip, they just run the syntocinon, and that is, again, that's what you're trying to talk about. You cannot be able to control this about the oxytocin. And this one brings about hyperstimulation of the uterus. Therefore, it means that it can be able to rupture. The other one is about use of prostaglandins to induce labor in previous scar mother. Though we are trying to say we need to have what you call VBAC, that is vaginal birth after cesarean section trial of scar. But now we need to be very cautious because it can bring about a ruptured uterus. The other one is real cause is mother in labor with 2 or more previous scar. Then intrauterine manipulation. We can also talk about trauma due to accident. When the mother falls down when they are pregnant, it can cause a ruptured uterus. Therefore, the other real cause is use of fundal pressure in high parity mothers. Remember, fundal pressure is something that we have discouraged to be performed by the midwives. But in most cases, you find these midwives are still using this fundal pressure to deliver the mother. Then we also talk about instrumental deliveries. When we're talking about instrumental deliveries, these are the AVD, assisted vaginal delivery, whereby we normally use instrument like a forceps delivery. We normally use a vacuum delivery. Maybe basically in some other lessons we come to discuss this like a unit on its own. Then finally, but not least, the real causes of ruptured uterus. We are trying to talk about perforation of non-pregnant uterus can cause rupture in subsequent pregnancies. So you as a student, you must be able to differentiate between the predisposing factors and the real cause which can cause the ruptured uterus. Then the other thing you should be able to ask yourself, if ruptured uterus has taken place, which is silent, like in cases of the dehiscence, you need to understand what are the signs and the symptoms that this mother can present, so that I can be able to know how do I need to manage this mother. Number one, we are going to talk about abdominal pain, all pain over the previous cesarean scar. There is also abnormalities of the fetal heart rate pattern. You can be get either deceleration and acceleration of the fetal heart rate, whereby you are trying to talk about tachycardia or bradycardia. Therefore, this one means you as a midwife, you must be able to understand, to know the normal range of the fetal heart rate, so that you can be able to know abnormalities of this fetal heart rate. The other one, you can get vaginal bleeding. You can get maternal tachycardia. You can also have poor progress in labor. Why are we trying to talk about poor progress in labor? Because we are saying contractions are normal. Because if it involves, it's for instance, if it is complete or incomplete or dehiscence, the second layer of the uterus, which is the myometrium, which involves in the contraction, we are asking ourselves, what is the function of the circular muscles? What are the functions of the longitudinal muscles, contraction and retraction. And that's why we are trying to say there is poor progress in labor, because now these muscles have done what? They have ruptured. There is also a formation of severe Bandu's ring. Bandu's ring is a saucer-shaped depression which normally occurs between the upper uterine segment and the lower uterine segment. Therefore, you as a student's midwife has like midwives, you need to be able to differentiate between the Bandu's ring and the retracted ring. And the retracted ring normally occurs in during the normal labor, which is just a small range of depression. The other one is about uterine contractions may stop. Where are they stopping? Because already they have done what? Ruptured. And we found the others we previously have seen there is what? Poor progress of what? Labor. Then mother may say that something is in her abdomen as given away. Because like when you talked about the complete rupture of the uterus, which involves the three layers, that is the endometrium, myometrium and the perimetrium. We say the baby is normally ejected to the perimetrium. So that's why the mother, they normally says there's something in her abdomen as given away. Then the fetal parts, they cannot be able to be palpated on the maternal abdomen. Then finally we can have what you call maternal collapse due to shock associated with internal hemorrhage. This is why we normally have what we call hypovolemic shock. Next time we shall discuss about management of these mother and how we can be able to prevention measures. Therefore, go to the Margaret Myers by Diana Fraser and try to see how can we be able to manage this mother. Bye bye.